Imagine you tested positive for a disease. Does that mean you have it? Does that mean there's a 90% chance you have it? Well, what if I told you in some cases that number can be 10%? But more importantly, how can you calculate that probability for yourself? And that's just one of the statistical concepts that everyone should know, which we'll be going over in today's episode.
We did part 1 a couple months ago, maybe?
Yeah, it was before you were here.
Yeah, that was one of the earlier ones. So you seem to enjoy that, so let's do part 2 of statistical concepts everyone should know.
All right.
All right. I'll show the concepts that we'll talk about in the beginning. The first one is your favorite regression to the mean.
Yes.
Then I want to talk about evaluating statistical model performance, but just on classification models, like predicting if it's a 1 or a 0 or true or false or yes or no, that thing. So not like a regression model where you're predicting a specific number.
Okay.
Then that will bridge, I think, nicely into evaluating a medical diagnostic test. Like say you go into the doctor and you get a test for something, like a PSA for prostate cancer or something.
Mm-hmm.
Those tests aren't perfect. So
Right.
what does that actually mean for you if you get a positive or a negative?
Okay.
And then to have a section where we don't need to talk about any math, we'll talk about the Hawthorne Effect.
No idea what that is.
You'll see. It'll be a good no math, just kind of talking
Okay.
about the concept. And then the last one is, what is causation? Which sounds obvious,
Right.
but you'll see. And this is all with a kind of backdrop of health sciences studies, that sort of thing. So you can apply these concepts to many different areas, but we're going to focus mostly on just like health sciences.
Right.
All right. Ready?
Yes.
So what is your idea of what this means?
I wasn't prepared to be quizzed, but
we can.
I guess the best way for me to explain something is to give an example. And let's say you're looking at sports teams and you see this one team that's been winning a lot recently and you think, great, I'll place some money on them. But it's most likely that while they have been performing well, you don't see the luck factor in the data there. So what's most likely to happen is that they will return to their average when their luck stops playing a role.
Yeah, that's the right idea. It's basically what I had was just that if you take an initial measurement of any value, it can appear high. And then if it does appear high, the next measurement that you take of the same value on average is more likely to be lower or closer to the average,
right?
To the mean. Same thing if it's on the other side, if it's too low, you would just naturally see the probability of it getting back closer to the average is high.
Like I guess it would be maybe a more intuitive example to say if we have like 5 different coins and we flip them, one of them is gonna have more heads than tails by like a lot.
Mm-hmm.
You might think, oh, this coin has a preference for heads, but in reality, if you just keep flipping the coin, it will regress to the mean.
That's the idea. Yeah. And like you gave the example of the sports team doing really well and then going back to their average. It can be like test scores or stock returns is a common one where the stock's doing really well for a time, but then it goes back to its average.
Mm.
Often, also, this happens with any medical measurement, like say you get a test for, I don't know, liver enzymes, and it comes back really high, but there's always some randomness in the test and in how your liver's enzymes are just, sometimes randomly higher for no apparent reason.
Shouldn't medical professionals account for that somehow?
There are ways to, but the easiest way is to just do another test.
Yeah.
Because, like, if you just have one value, it's not enough evidence really to say, is it going to go back? Is it just a regression to the mean problem where it'll go back to average on its own? Or is it something actually happening?
What I'm getting at is, if somebody does some test and the doctor's like, this looks bad. If it's something that this concept would apply to, I'm assuming that the doctor would be like, there's no need to panic. We should do another test in a week or something.
Yeah.
So they would do that, and not like you have to be like, well, actually.
I mean, depending on the test, like depending on exactly what the test is, of course. But yes, that is usually what happens. They'll order a retest in a week or two or whatever, and they will say, "Don't panic. It's probably okay." Obviously, it depends on what the value is and what's being measured. Yeah, usually the procedure is, let's check again. It might be just a random measurement error or just a bad day or something, But it does depend. So in my slide, I just said regression to the mean means that a very high or very low first value measurement of that first value, it's likely to be closer to the center, the average on retesting. And this can also, like in medical studies and health studies, can make a treatment look like it's effective.
Yeah. When
it's just a regression to the mean problem. For example, if to be included in the study, you had to have a very high LDL or very high liver enzymes, and then they want to test, does this supplement decrease those values? Then it could be that it was mostly just due to regression to the mean that values on the next test are lower.
There's only so far high up it can go as well, so.
Yeah, I mean, yeah. So I want to talk about how they deal with regression to the mean in health studies and nutrition studies.
Okay.
Because I think it's a really interesting idea that you hear a lot about, but you don't hear how it can be dealt with in studies.
Okay.
So there are two main ways to deal with it, and they have to do with how the study is designed and how the data is analyzed. We did talk about some study designs in the previous couple of episodes. So one of the things that they can do is with those, like if you have an inclusion criteria of a high value, you just do multiple measurements to make sure people are actually at the higher value and it's not just a regression to the mean. And similarly, you can just have a period where you just put some time between the first measurement and then the next measurement, and you just make sure there's the inclusion criteria is still met there. But I think the main thing that you can do in the study design is just do a randomized controlled trial.
Right.
And then you can compare two different groups. And if there is regression to the mean, you can just analyze it in a way where both groups should have it similarly,
right,
if it is there. And then you just see how much better was the other group, the treatment group.
Gotcha.
Another way is with the data analysis side, there actually is a way to estimate how much regression to the mean will be there given a specific measurement, but it's not very straightforward. You need a lot of other data about like the population level average, and you actually probably need multiple tests of that same person. So it's not the best way to go about doing it. The easier way is just to do a specific kind of model called this ANCOVA model, analysis of covariance, because in this model you can control for the baseline differences, which I was talking about in the study design.
Okay.
This is just how you would analyze that study design data. And if you want to actually quantify how much regression to the mean effect there is, you need some kind of reference mean, like a population mean, to figure that out, ideally.
Okay.
I'm going to go through an example of this, actually. So, how to deal with regression to the mean. So, I want to just imagine a study we're going to do. This will be, we just make this study up. So, let's say we just want to evaluate the effect of a vegan diet on lowering cholesterol levels over 12 weeks compared to another group that just continues their normal diet that they eat. So, the only thing we're changing, ideally, is vegan diet, and then the other group just keeps on with their normal diet.
Mm-hmm.
And let's say we have some inclusion criteria, just, we decide it's going to be adults 18 to 30 years old, and they have to have high cholesterol. But we only put it at a single screening measurement. So if they're above that level of LDL cholesterol, they can be in the study.
Right.
Not ideal, but let's just say we did this.
Yeah.
Okay, so we have those. The intervention is just the vegan diet, and then the other group just goes on the usual diet.
Right.
And we randomize the people in the study, of course, to which group they're in. And our primary outcome is that change in LDL cholesterol. So we measure it at week 0 and at week 12, the end of the intervention. So let's say now we're going into the data analysis. Okay, so I'm going to show a chart. And I'm first going to look at the usual diet, the change in LDL over 12 weeks. Okay, so each point in this chart is a subject or participant of the study.
Yeah.
And you have week 0, and you have the LDL reading for each subject, and then you have week 12, which is just after the study, the same subjects, their LDL readings. So the lines are indicating it's the same person.
Yep.
And the solid line is just the mean, the average for each one. So what does this look like?
It went down.
Right. But why?
Because it started high.
So you're saying it's...
I'm saying it's inconclusive because it could be regression to the mean.
Yeah.
Or at least partially.
I would say almost definitely at least partially.
Yeah.
Yeah. If we assume that nothing changed,
it would still go down.
Then we can say it's probably almost all regression to the mean.
Uh-huh.
Okay. Now I'm going to show you the people on the vegan diet. I'll show you their results. So what do you think of that?
What's your question exactly?
Does it look different to the usual diet?
Yes.
Okay.
It started a little higher and ended up a little lower.
Right. So you would guess probably that maybe the vegan diet does lower LDL cholesterol a bit more.
It would, yeah. I mean, it would depend on my background knowledge of these units and how big of a difference this is, which I don't have.
Mm-hmm.
But if this, because it's like, I mean, on the chart, it looks like it's a little higher and then a little lower. Yeah. But if that's like a significant amount, it could be indicative of something.
Cool. All right. Well, let's figure that out.
All right.
So we're going to do... yeah. Sorry for yeah. So we're going to do that, basically how we'd analyze this to figure out if the difference is significant or if it's not. And we're going to use this kind of ANCOVA model, and it's a baseline adjusted, so mean centered by the average LDL. So we're kind of we're mean centering their baseline by subtracting the overall mean from every subject's baseline LDL.
You lost me.
Okay. So the baseline LDL for every single person is like, I think let's say we had like 44 people in the whole study. We are subtracting the average baseline LDL from all of those. Since we're comparing two groups,
Yeah.
we don't need to worry about regression to the mean, because we are just looking at what the difference is between these two groups, and because it's a randomized controlled trial, we're assuming everything else is held constant, and the only difference is the vegan diet. So if we remove...
What is the minus 25?
That means that on average, if you're in the vegan diet group, you have a 25-point decrease in LDL compared to the non-vegan diet.
Okay. So it's compared to the non-vegan diet.
Yeah.
Okay.
Yeah.
Gotcha.
With p-value of less than 0.05. And the actual, just to show you the actual changes on average.
Right.
In the usual diet, it was negative 41.2, and the vegan diet was 67.2.
Right.
That is basically what the difference is.
Yeah.
Basically, because it's a randomized controlled trial, if there was regression to the mean, which there definitely was,
you're assuming
we don't
that
need to worry about that.
Equally applying to both.
Yeah, it should be. Yeah.
It should be, but the one of the groups had a higher starting point.
Yes. You're never going to have exactly the same starting point.
Mm-hmm.
And we account for that in the model.
Okay.
Because we have enough people, it's fine. Like if you had, 10 people, maybe you wouldn't have enough to be able to account for that in the model. But here we got enough. It's okay.
Okay.
That's basically it. Like there's nothing more complicated. Like
you just subtracted one number from the other.
What's the problem?
It's very simple.
It's not the most complicated statistical analysis that you can do.
But wait, I thought, how does this relate to regression to the mean then?
So the idea is that both groups definitely had regression to the mean.
Mm-hmm.
But because this is a randomized controlled trial and we randomized the groups, we can say that in each group we should have the same amount of regression to the mean.
I guess my expectation was that you're going to have some fancy math to account for the difference in starting values.
So that this little difference?
Yeah.
231 versus 232.
Yeah.
So it accounts for the difference in the baseline because the baseline is in the model here. The baseline is included as a covariate in the model. It is here, but we're just, subtracting the mean.
I'm going to regret asking this, but doesn't that assume that, I don't know if I'm phrasing this right, but that the regression is linear?
Yeah.
And what if it's not?
You use a non-linear model.
Okay, I'm going to accept that answer.
Yeah. Summary. So regression to the mean just means that extreme results, they just happen by chance sometimes. And usually if that happens, the next measurement is likely to be closer to average.
Yeah.
It often makes this look like a real change, but it could be just regression to the mean. In studies, we can use controls or baseline adjustment to avoid that.
In the book, that I mentioned to you before, the Thinking Fast and Slow. The author is hired to evaluate some training that they're doing to Israeli jet pilots and to figure out which ones to promote. And I don't remember exactly but the gist of it is the ones that they were rewarding ended up performing not as well. And then he figured out that they were basically rewarding luck.
Yeah.
That was an interesting example.
Yeah, definitely the similar kind of thing. They're doing better for some time, and you think it's from skill.
Yeah.
And surely
some of
them probably
course,
were,
yeah.
but yeah.
But even the skilled ones can be lucky and be more skillful than their average, and then go back to their average.
Right. Yeah. That is, yeah. Cool. Next one.
Let's go.
This will be fun. Evaluating model performance. So that's like a statistical model, and then medical test results. I'm not going to go into actually how we build the model. I'm just going to show you what goes into it and then the result.
Okay.
Because that's nobody wants to hear that. I assume. Okay, so I'm going to use a data set that's just available publicly. And the outcome in this model that we're going to build is coronary heart disease.
Okay.
And it will be yes or no.
Okay.
So not how much do you have? It's just, do you have it or not have it? And this is an example of a few rows of that data set. So you have each row is a patient. You have their systolic blood pressure, tobacco use, how adiposity, how much fat they have. Is there a family history of heart disease? Are they type A personality? Like,
okay.
The degree to which I don't know.
No, wait. What is that?
Type A?
Yeah.
The degree to which they're of a type A personality, like how, I don't know, neurotic and like active and.
I've never heard that term before.
Oh no, okay. Yeah. It's just somebody who's always got to be doing stuff and like never relaxes.
And this is measured. There's a metric for it?
Apparently there is. I don't know too much about this specific one.
Okay.
But, okay. And then an obesity level, alcohol use, age, and LDL's in there as well. And then that final column, the CHD, is coronary heart disease. Does the patient have it or not?
Mm-hmm.
Okay, and we have a few hundred patients in this data set. We're just going to magically build a model that will predict yes or no, does the patient have it? Okay, so this is the model output. That's just a few examples of patients. CHD is the actual, like, do they have it? Mm-hmm. And the CHD predicted is what the model predicted they would have based on the data.
Gotcha.
So you can see that there's some that are actually no, and then were predicted no, but there's also some that were actually yes and predicted no, or actually no and predicted yes.
Yeah.
So and these are different kind of errors, mm-hmm. right? The terminology is it a true positive, both positive, the prediction and the actual, or is it a false positive, meaning we predicted it was yes, but it's actually no? And the same thing with true negative or false negative. And our overall accuracy in this model we get is 0.74. Mm-hmm. So that means 74% of the time we are correct.
Right.
So you think it's okay model. It's not horrible.
I mean,
it's not great, but
it depends on what percentage of people had it to begin with, I think.
Good one. It does.
I have my moments.
So now I want to talk a bit about how we evaluate this in a statistical or data science type way, talking about the true positive and true negative and those kind of things. And the common thing to do is make this kind of 2x2 table that's called a confusion matrix.
Mm-hmm.
And it just shows a count of the predictions and the actual values.
Okay.
So if you see the blue, that is a true negative. So we predicted no and it's actually no.
Right.
And then the green is predicted yes and actually yes. And ideally, we'd want everything in the blue and the green.
Right.
Of course.
That would be 100% accuracy.
Yeah, yeah. But we have some that we predicted no and some that were actually yes and some that were predicted yes but actually no. And from this confusion matrix, we have some other metrics on top of accuracy that can make it more clear how well we're doing with these different kinds of different metrics.
Yes.
I'm going to show you a few of these and the formulas, but I don't want you to worry about exactly what
I can't
how to
promise
calculate
that.
them.
But just to put your mind at ease a bit, I think I'm familiar with where you're going. But go ahead.
Okay, so here are those metrics. We have the accuracy that we saw before, which is just everything overall. How well are we doing? Then we have one called sensitivity, which is like of the actual positives, how many of those did we get?
Mm-hmm.
Then we have something called specificity, which is of the actual negatives, how many are we ignoring? How many are we saying are actually negative? And then we have something called precision, where if the model predicts that it's a positive or a yes, how often is it correct? So don't worry about that. These are just different metrics we have to evaluate the model.
Yeah.
And it's always a trade-off between these metrics. Like you can force it to have a high sensitivity, but then you have, lower specificity, things like that.
Yeah.
There's ways to optimize these things, but it's beyond this scope at the moment.
No, I get it. Yeah.
Basically, I just wanted to show that there are different kinds of errors in these classification or models that predict a yes or a no or a 1 or a 0. And we have these different metrics to deal with that and to analyze them. So just a summary, accuracy is good, but it can, like you were saying, make a weak model look good if the data is imbalanced. If we have like 99% yes.
The example that I like to give is the city I live in barely rains. And if you look at the weather, there's often some day that says rain. And I always say that I could write a better model by just print sunny every day without any calculation. I think it would be correct more times.
Mm-hmm.
Just because there's such a high rate of sunny days.
Yeah.
But I think people care more about knowing if there's a slight chance of rain. So that's when the sensitivity and such come in.
Right. Yeah, that's good. That's exactly, but the opposite way that when I was studying statistics in Ireland, they would make the example, we can build a model that says it rains 99% of the days of the year and it's going to be perfect almost.
Yeah.
But like, it's a crappy model.
Yeah, exactly.
Doesn't help. Yeah. So in building these models, if you have to figure out which kind of errors are more important to you, the false positives, false negatives, and how you want to make that trade-off. And of course, there's no, you can't say one metric is always better than the other. It depends on the situation.
Of course.
And it's always interesting to figure out where to put that threshold to figure out if it's where you want to, which one you want to reduce and which one you want to say get more of. All right.
Maybe we should give an example of an extreme case where if you're testing patients to have to diagnosing them with something that would be very, very dangerous to have, but easy to cure if caught early. You want a model that, like, you don't care if it misdiagnoses some negative ones. The important thing is it gets all the positive ones correct.
Yeah, and then there's always trade-offs. Like, you don't want too many people to have to go through further tests and
cost-wise
further
and stuff.
problems. Yeah, cost-wise and
right,
once you start doing medical procedures, then more things could happen.
Okay.
So even with that example, there's still like how much of
where do you draw
how much
the line?
do we want to accept? Yeah, where's the line? It's difficult. It really is. Yeah. Which is a good bridge to our next section on medical diagnostic tests. So we just saw in the statistical model the different error metrics, but now let's kind of like you were just saying, let's kind of apply this thinking to a medical screening or a diagnostic test that isn't perfect. Because some like if you I don't know if you're doing a actual tissue biopsy, it's almost perfect that you can figure out what the problem is.
Right.
But if it's a screening test, then it's not a perfect test. There's some error. And then the question becomes, if you get a test and it comes back positive, what's the likelihood you actually have the disease or the condition or whatever? And conversely, if the test is negative, how likely is it that you actually don't have the disease?
Right.
For a test. Some similar metrics that I'll introduce will answer these questions, and that's called PPV and NPV. And that is the positive predicted value of the test and the negative predictive value of the test.
Okay.
Let's work through this with an example. So let's say, similar to the model we built before, let's say now we have 10,000 people get tested for a disease. We're building the model. And 200 have the disease. And we build a model for that, and we get this confusion matrix out of that. So most people don't have the disease, of course.
Right.
Only 200 out of this, so like 2% have the disease.
Yeah.
So that looks pretty good. And of this, we have our true positive, we have 90, so not too bad. But we have some where we predicted yes, and we're actually didn't have the disease. We have 99 of those. That's the orange.
Yeah.
And then we have some where we predicted no, but we're actually yes.
Yeah.
And that's like a false negative where we thought it was negative, but it's actually yes.
Right.
And probably in this case, it's good that number is on the lower side.
Right. I thought it was still too high.
It may be too high to your liking, for sure. Yeah, but it's difficult.
It depends on what the disease is as well.
Right, you're right. Of course.
If it's a cold, then whatever.
But yeah, well, I haven't made that up yet, so.
Right.
Okay, so let's just say those are the accuracy, the metrics that we have, the ones that we talked about before. Don't worry too much about the calculation. Just those are what they would look like with that confusion matrix. But now I'm going to show the positive predicted value and the negative predictive value. The positive predicted value is just the same as precision actually. So it's
I'm noticing.
Yeah.
Why make the exact same whole...
I know, it's just in this situation they like to call it the positive predictive value. Just different areas call it something different.
You're on very thin line.
I'm sorry.
Continue.
Okay. And then we have the negative predictive value, which is basically how well we do at predicting negative. And we're really good at that.
Yeah.
Like we're close to perfect. But the positive predictive value isn't that great. It's only 0.48. Okay. What does this mean if you take the test? If you take the test and it comes back negative, how likely is it that you actually do not have the disease? It's just that NPV. It's just that 99.9%, the 0.99, same thing. So that's really that's really good. if you get that result and it's negative, you can trust that as much as you can trust almost anything.
Yeah.
However, what if you take the test and it comes back positive?
48.
Right. It's 48% chance that you actually have the disease. Why only 50% or 48%? So it's basically because most people just don't have the disease.
Yeah.
And it's difficult to build a model that is really perfect for predicting the positive. And the prevalence of the disease is very low.
Right.
The prevalence is 2%. And even if we have those high metrics and the other, those high values in the other metrics like sensitivity and specificity, because it's pretty rare, we just won't have as high of a positive predictive value. The next slide, I'm going to go through a real world example on mammogram screenings.
Okay.
And I'd like to say this is not medical advice. These numbers are about correct, but don't take this to the bank or,
Don't sue us.
Don't sue me. Don't sue me, bro.
Yeah, don't sue him. 'Cause
Don't sue me, yeah. All right, so it's actually the confusion matrix for this model isn't too far off from the other example that we just built. And here the prevalence for breast cancer is 1%. And yeah, because 10,000 were screened, 100 have cancer. So in this model, we have a positive predictive value here of 11%.
Yeah. So if you get diagnosed with a positive,
you get a positive,
you have an 11% chance to actually have it.
Right.
And you said this was real world data.
It's moderately accurate. Like there's different studies where it's somewhat different than others.
Okay.
So I just want to say it's in the ballpark.
Okay, I'm not saying this is real because I'm trying to get an answer and you're being too American for it. This may not be real, but you didn't make this up.
Yeah, it's not real, but I didn't make it up. Yeah, exactly. Okay, so the negative predictive value is very high. If you get a negative result, it's almost for sure that you do not have breast cancer. However, if you do get a positive, there's an 11% chance. But remember that this is in comparison to that prevalence, which is 1%, and having an increase absolute probability of 10% is substantial, I would say, especially in this kind of disease where, it can be deadly. And if you get it early, it doesn't need to be.
Yeah.
So again, it's that trade-off.
Yeah. You're not just trying to get the highest accuracy. You're looking for something specifically.
Right. And taking into account
whatever.
Can you identify it early? Yeah. And can you fix it then?
Yep.
Or treat it? Just a summary of those two sections. So we talked about the model performance, which is just looking at the data set and how well it does on that data set. But then we looked at the medical testing, which is kind of applying that to an individual person when they take a test and get a result. So we can use those same error metrics to judge a model to also determine what the test result means for an individual. But we have to account for how common that condition is, so the prevalence of that disease or condition.
Right.
And like I was saying, even if you think it's a low positive predictive value, don't just throw it out. Take into account the context.
Of course.
All right. Let's move on to the non-math section.
Oh, that wasn't math. That wasn't much.
It wasn't too bad. I tried to skip over the actual calculations.
It helped that I had seen a lot of it before.
Cool. So let's talk about this mysterious Hawthorne effect, which isn't really that mysterious. It's just a different name for what you're probably already quite aware of. The idea of this is very simple. It's just that people change their behavior when they're being watched, which is totally obvious. But this is just how it was called in the scientific literature, because back in the 20s and 30s, they were doing studies at this factory called at this place called Hawthorne, and they found that if they just monitored people in the study, they would work much better.
Okay.
They wouldn't tell them like how they're monitoring them exactly, or what they're monitoring them for. They would just notice that if the people were made aware that they're in a study being watched, they would work much better, more conscientiously, whatever.
Okay.
They basically saw that productivity increased. And in the literature, there have been a lot of, I guess, discussions about, does this matter when we make any study? Like, should we try to account for people changing their behavior when we put them in a study? Like for example, in that vegan study, vegan versus usual diet, we say that the control group should stay on their usual diet, but now they know they're in a study.
Yeah.
Are they going to be more careful with how they eat?
For sure.
Just because they're in a study, yeah. And the researchers have also said that there's no like single Hawthorne effect, that it might change people's behaviors, but it's unclear exactly how. So it's not really specific and might not be that useful to think about even.
Okay.
And you might be thinking, well, how do they actually study that? Like, how do they study people ethically without having them know that they're in a study?
They do it in the 20s.
They do it in the 20s and they don't tell them. Yeah, maybe. Yeah. But they, like, the modern studies have kind of tried to analyze this by saying that, okay, we're going to say you're in a study, but we're not going to tell you exactly what we're monitoring, because they want to be ethical and not just observe people without telling them. That wouldn't pass the ethics committee. So they at least have to tell them they're in a study. Okay. So what they do is they kind of would say they're monitoring, I don't know, many things in, like, say, one clinic, but at another clinic, they'll just say, you guys are in a study. And they won't tell them what exactly they're monitoring, and they'll try to compare the two and see if there's a different rate between the clinic that they told them they're monitoring this specific thing as compared to one where they're just generally monitoring. And it's not exactly the ideal study, but it kind of maybe approximates a little.
Okay. So at one clinic, they'll, for example, say they're studying their weight, but they measure the weight at both clinics and see if
on like an overall thing that they're measuring lots of things. Yeah.
And they'll see if the change at the ones that knew what they were studying was any different than the ones where people didn't. Okay.
And as you can imagine, they're mixed effects. Some studies found there is an effect, some found there isn't, So this quote that I have was from a meta-analysis of a lot of these Hawthorne type studies. And they basically said the Hawthorne effect label has stuck around for so long simply because we have not advanced our understanding of the issues that it represents. And we suggest that the unqualified use of the term should be abandoned.
Mm-hmm.
So they're basically saying it's kind of useless. Like we can't really do anything with the term. It doesn't help.
Okay.
But one recent study that was about the Hawthorne effect on wearables, like the Aura Ring and, tracking devices, was said that clinicians might consider harnessing the Hawthorne effect to increase behavior change and positive outcomes. Which sounds nice, I guess.
But what does that mean?
Let's say you want to you want your patient to start walking more than they had been, get their steps in.
Yeah.
And you give them an Oura Ring or a Apple Watch that'll track their steps. This study was saying you should tell your patient you're being monitored. Your steps are being monitored to try to have them increase their good behavior of doing more steps. That's the positive outcome.
Sounds very trivial.
I mean, it's trivial, but it might. I think there is an effect, at least initially, maybe, that people try to, so they're being tracked. They're like, oh, I gotta.
No, I can totally see why it's something that needs to be taken into account when conducting studies, for sure.
However, I'd also mention that if you're in a randomized controlled trial, maybe it is accounted for because you're randomizing to groups and you're assuming that both groups would have the same Hawthorne effect.
Right. It's not I don't think it's an issue, or at least as much of an issue in every type of study. But for example, in the one that you said, where one group was supposed to change their diet to vegan while the other one was supposed to just keep eating what they're doing, then it's like kind of built into the study that they don't change their behavior.
Right.
And they probably somewhat did.
I would say it would be unlikely if they didn't change their behavior, at least somewhat. Yeah. Yeah. It's just interesting to think about, I think.
Yeah, for sure.
And then I guess my last thing about this was, does it matter then?
Didn't we just answer that?
Yeah. Well, anyway, does it matter? Maybe.
It depends.
It depends. If it is real, I guess it could inflate some effects, just like the regression to the mean thing. But if the study's set up properly, it's at least maybe less of a problem.
Sure. It's just something to take into account, but not like abandon all.
Right, of course. Not just say all the studies are useless if this effect is true. Yeah. And also one of the things that was mentioned in some of the studies was that the effect is, if there is an effect, it's probably stronger in the beginning.
That makes sense.
And as it goes on, you just get used to it and kind of go back to your normal behavior.
When I got any type of wearable, the first week I would check it obsessively and then just forget about it.
So it's definitely that kind of thing. And I think in the end, this was my conclusion.
Well, the first day that I put on an Oura Ring, I didn't sleep. Like, and like as soon as I would like just get like 5 minutes of, I would just wake up. Like, did it register something?
I guess that's the opposite effect. Then it's like, that's the anxiety effect.
I guess, but it's something.
Yeah.
When I got a Fitbit back in the day, I went on longer walks. In the beginning, just to.
And then I just
get the numbers up.
Yeah.
just to hit that 10,000 goal, and then I just forgot about it.
Yeah. So that was kind of that's kind of why I ended with we're all Hawthorns now.
No, I think it was. I haven't seen it. I think it's useful and doesn't often come up.
Yeah. Last section, the most fun. What is causation?
Spicy.
Okay, this was inspired by many YouTube comments I've seen.
You're reading YouTube comments now?
I mean, sometimes I do on the health videos about studies. Yeah, it's interesting. I know it's probably half of them are bots, but probably more than that. But
I don't know. YouTube is more.
Maybe less. Maybe less than
Twitter or something.
Twitter, X, whatever. But I don't use that, so. Anyway, okay. So I've got my YouTube comment causality logic framework that I have built here.
Okay.
It goes like this. So this is like a YouTube commenter, how they argue about causality. They say, you claim if we do A, B will happen. Well, I know someone who did A and B didn't happen. This proves A doesn't cause B.
Okay.
So I see this same kind of logic. Like they have like one example where they know somebody who did the thing that this study claims causes something else, and they think that refutes like the whole causality of the study.
So anecdotes, essentially.
Yeah, in a way, but I think it's more than that, because what I want to explain just more clearly in this section is that in the health sciences, causation isn't deterministic, it's probabilistic. I'll explain more what I mean by this as we go. And so I have here a simplified definition of causality in the health sciences. And this health sciences like epidemiology, nutrition studies, public health, this kind of thing, biology.
Okay.
This is simplified, remember. So if all else is equal and we change exposure A, that changes the probability or the risk of outcome B. Then we say that A is causal for B. So change the level of A and outcome B, probability increases. Then we say that A is causal for B.
Right.
If we assume everything else is held constant.
Yep.
That doesn't mean A always causes B. It means that it changes the risk of B occurring. In this terminology, I want to say that we want to think of cause and causality as a risk factor.
Yeah.
And I think it's this cause word, this causality that people get hung up on.
Lexical issue.
Yeah.
It's so direct.
Right. It's direct. They think it's like the classic logical cause.
Right.
Like if A then B. Like
yeah.
Deterministic.
I dropped the glass and it broke.
Right.
So.
And just to then further specify, when we talk about risk factors that you can change, that just means that it's modifiable. You can change that risk factor. So in health sciences, you'll see a risk factor is age. You can't change that. So that's not a modifiable risk factor. So in that area, you want to focus on the risk factors that you can change.
Yeah.
That definition is a bit simplistic, but I think for our purposes, it's good enough.
How is that simplistic? It's way less simplistic than the traditional definition of cause.
Right. But I don't want to go into being very precise, because you can argue against this definition that, okay, but what about it's just an association, it's not a causation.
Okay.
How are you sure in this definition it could be just an association,
Okay.
and it's not, the risk factor isn't the true cause.
Sure.
I just want to state that. Okay, fine.
But if it's an associate, okay, whatever.
Yeah, if you can change it, then I know. Okay. Okay. So yes, it is more complicated. Then if we say that causality is probabilistic and not deterministic, like you're saying, like how do we know if that thing is causal? How much evidence do we need? Do we need randomized controlled trials? Is there a guidelines or rule book or criteria to like add up the evidence to figure out if this factor is a risk factor that's causal?
Mm.
Or if it's just an association, who decides? So, of course, it's not that simple. It's not like a math theorem that you can prove. You have to just build this case, almost like a legal case, where you look at all of the different avenues of evidence. You look at different study design types. You look at observational studies. You look at randomized controlled trials. You look at mechanistic studies. You look at meta-analyses of all these things, and you try to combine everything to determine if it's causal.
Right.
Okay. I want to talk a little bit about some guidelines that are used, but not go into too much detail.
Okay.
I'm saying, is there a rule book that defines it? Not really, but there are guidelines. And the most widely cited is this called Bradford Hill criteria. And that was a health researcher back in the 50s. He wrote the criteria, I think, in 64, but it was based on his work linking smoking to lung cancer that was done in the 1950s.
That's a good one to base it on.
Yeah, but it's not a rule. There's no like, you need 4 randomized controlled trials that show an effect higher than blah, blah, blah. It's just a framework of how to think about it. There are some more modern methods, but these are still really important. And these criteria, just quickly, they just talk about how strong is the association with the outcome. Is the result consistent across different study types? Does the cause actually precede the effect?
Right.
Which I know sounds obvious, but
No, yeah.
you can't get tripped up there. Is there a dose response to the factor versus the outcome? Is it plausible? Just does it make sense logically?
Right.
Is it coherent with the existing scientific knowledge? Does the experimental evidence support it, like the randomized controlled trials and interventions? Are there other similar causes that are already in the literature that you can look at? Things like that. Those are like the main criteria quickly. But then the question is, like, if you have those criteria, how do you accept it? Like, who accepts it? There's no, it really depends.
It felt like you were building up to an it depends.
I know.
For like several slides.
Yeah, right. Yeah, so I mean, at the least, you would want multiple independent studies with multiple systematic reviews and meta-analyses with the same evidence and across different methods. Then still, who decides? And generally, it is some sort of group or organization that puts out a consensus and like says, we think this has enough evidence to be determined as a causal effect. And like there's no magic thing, like that's it.
At the risk of throwing you a curveball, Have they ever been wrong?
I think you can't say no. Should I say no? I, I think they have. There's have been instances where they've not been.
If you want, you can answer off the record.
No, I mean there have been instances where, yeah, I think you could make an argument that they have been wrong.
Okay.
However,
They're mostly not.
I would say they're mostly not, and generally they have made a strong case, and you can read. You should be able to read all of the evidence that they gather, and make your own determination if you want to.
Right. The thing that I would add is people tend to throw the, what do you say, baby out with the bathwater. Like, did you see they were wrong about this one thing?
Right.
I'm never
We
gonna
can't
trust them
them.
again or something.
Yeah.
So
Yeah.
but I'm hoping somebody who has an interest in either data or health stuff enough to watch our long stuff isn't of that mindset, and we can safely say that.
Yeah, I mean, if you want to throw it all out, fine, but then read all the studies,
right,
and make your own decision.
Sure, yeah.
Don't just throw it all out.
Right.
So, yeah, like I was saying, it's not automatic. It's slow. I have 2 case studies of how this went down. So the first one is what we had mentioned, the smoking causes lung cancer.
Right.
So basically, brief timeline, obviously there's much more detail that you can go into here, but back in the 30s, the researchers were seeing, there's a rise in lung cancer, some suspected smoking, and then all the way until the 50s, where we finally got some major like case-controlled studies trying to compare different groups that didn't smoke, that sort of thing, and look at the lung cancer rates. One of these was the British doctor cohort, and that confirmed there was an association between doctors who smoked and doctors who didn't with lung cancer. And in 1964, the U.S. Surgeon General, this is the report that I'm talking about. They put out a report saying that we believe smoking is causal for lung cancer. And actually, initially, it was only about men.
Right.
And then later, they extended it to women. I guess because they only studied men initially, and then didn't want to specifically
That's
say,
weird. Did they specifically say it's for men?
Yeah. Strange, but it's different times.
Yeah, but also, like, if that's what the study said.
Yeah.
I mean, I'm hoping women didn't go like, "Oh, we're cool then. Let's just."
Yeah, I hope not. I'm sure the cigarette companies were like, "Oh, we'll just
market it for women
promote
for a
it to
couple
women,
more years.
Yeah. And then later on, you got the actual like DNA cell mechanistic studies that confirm this, of course. But by then, it was totally accepted that smoking caused lung cancer.
The only thing that I wanted to ask is, you went from association to mechanistic, and you usually like to see randomized control trials.
There were not randomized controlled trials that studied smoking on lung cancer.
Was just good enough to call it as it was.
The association was so strong that it was like, it would be virtually impossible that it was not the smoking.
Cool.
And then if it's that strong, then you have the ethical problem.
Of course.
Because you have, like, you're going to follow people for 10 years and see if they get lung cancer.
Make people start smoking.
Right, randomized. Yeah. Yeah. So, yeah.
They did
And
do
that
it
was
with animals, though, didn't they?
uh probably I would assume they did. I'm
Okay.
not
I'm not sure either.
100% sure. Um yeah, so then scientific community accepted that without the randomized controlled trials. And all of the major organizations did, of course.
Okay.
It was just so clear.
Yeah.
Okay, the next study is a more modern time period. Still not like not very modern, but so this case study is on trans fats and their association with heart disease.
Right.
So that trans fat is just a type of fat that's made in a chemical process without getting too detailed about it. And it's the thing about them is it's solid at room temperature. So they're very good for keeping like baked goods fresh versus like using butter in it or something.
Gotcha.
It just lasts longer. And that's what they were used for initially, mostly in processed foods. And early on, the studies lumped them together with saturated fat because they are a type of saturated fat. But in the 90s, there was a lot of research that identified that they might have specific harm due, specifically heart disease, cardiovascular heart disease, coronary heart disease. Sorry. And in the 2000s, there was more of this biological and mechanistic studies that were done on these types of fats. But this was all built on large prospective cohort studies, like the Nurses' Health Study, Health Professionals Follow-Up Study. And they identified also strong dose-response relationships, strong evidence that trans fats significantly raise LDL and at the same time lower HDL and increase inflammation and in endothelial dysfunction. And that was consistent across all populations and all different study designs that they did.
Mm-hmm.
Same thing, no randomized controlled trials,
Wow.
except for the earlier ones that just happened to have it in there.
Right.
There wasn't specific ones. And this wasn't that long ago. Like I remember this going on.
Mm.
Back in 2006, they started requiring it on the label in the US.
I remember it was a big deal in the 2000s.
Yeah. And then 2015, FDA said it's no longer generally recognized as safe ingredient.
Is it still used?
No, it's basically banned in the US food supply.
Oh, cool.
I think in some countries it's allowed, but I'm not sure. I think it's effectively banned
Right.
almost all over the world. There is some naturally occurring trans fats out there, like, but it's so minuscule
Okay.
that it doesn't. It's only when you actually start doing it in a chemical, industrial fashion that the amount becomes problematic. No randomized controlled trials. It was just this causal claim built on epidemiology, those cohort studies, mechanism, and evaluating policies that either didn't allow trans fat, and then they looked at what happened to the heart disease rates compared to places that did allow it.
Right.
Okay, last summary of this section. So the whole causation thing in health sciences, I just want to be clear, we don't think of causation as deterministic. It is probabilistic. It's a complex system. The definition simplistically is that if all else is equal, changing A changes the risk of B occurring.
Right.
And I think it's better to think of those causes as risk factors to avoid that, like, I don't know, emotionally charged word as cause.
Yeah, I think the best thing you said about this was try to disconnect from the traditional definition of the word cause.
Mm-hmm.
When you're just colloquially say something caused something, it means something different than here, where, as you said, is probabilistic.
Yeah, exactly. Yeah. So I'll just finish this one with a statement. So there's little certainty, but changing risk factors you can control can lower your likelihood of disease. You can call it cause or not, but
Gotcha.
we just care about a risk factor being a real thing that can change the likelihood that you'll get a disease. That's the thing. That's the thing we care about.
Right. It's just what is the input and what is the output, and it's not always a 1 or a 0. It's they compound over time.
Yes, definitely, for sure. Okay. So just to summarize everything we talked about, the first thing was regression to the mean, which simply is just that extreme values usually drift towards the average when they're measured again. And in studies, we can deal with that. It's not that complicated. Just be aware that it is possible. It is a real effect. And then model performance, we talked about accuracy is not everything, and that there are different kinds of errors, and it always depends on the context, which one is more important than the other, and it's always a trade-off. And linked to that is the diagnostic test. So if you take a medical test, a diagnostic test, you will get a yes or a no, but it's a probability in there, and it changes your probability that you have a disease or you don't. And those are based on the positive predictive value and negative predictive value of that test, which really depends on the prevalence of the disease. And don't throw out a low positive predictive value. Consider the context.
Yep.
Hawthorne effect was just, if you're being observed, you might change your behavior. But we're all Hawthornes anyway, so it probably doesn't matter. I mean, it matters, but...
Right.
The last one about causation, just think of this as a risk factor. And if you can change the risk factor or not, then you can change the likelihood that you may have a disease or not. And in thinking about this whole causation, just think about it as a risk factor, and is the evidence behind that risk factor strong, and is it something that you can control?
Yep.
And don't throw out the baby with the bathwater.
Yeah.
The organization's determining that something is causal, and maybe they're not correct 100% of the time, but if you're going to throw it out, please read all the studies that they reference.
Like, we used a very medical theme to everything, but I think I've come across a lot of these almost always in a non-medical setting, so you can definitely apply these to wherever else you might use data in your life.
Yeah, these same ideas and metrics are used in many different areas.
Yeah, as with the regression to the mean, with the pilot example.
Model performance, I've done classification models like this on identifying malware.
Okay.
Same metrics.
Yeah.
Yeah. Okay. The next podcast I want to do is to revisit that keto CTA study.
No, actually, it seems, much to my surprise, people seem to have watched it.
You know why I want to go back?
Because there's more.
Because I have some of the data.
Oh.
And I have enough data to say